Okay, so this topic is only based on immunotherapy in allergic rhinitis. Immunotherapy can be used in other kinds of allergies, such as bee or wasp allergy. Or yeah, I have no disclaimer. Okay, so we're going to talk about mechanisms of allergen immunotherapy, indications, and then its efficacy. And then we'll compare the two: subcutaneous immunotherapy versus sublingual immunotherapy. So allergen-specific immunotherapy has been there for donkey of years, over 100 years, as a desensitizing therapy for allergic diseases. And it not only affects rhinoconjunctivital symptoms, but it leads to also short and long-term benefits in asthma treatment. And I believe Dr. Deval touched on it in one of the Q&A asthma sessions. So what is allergen immunotherapy? It's the repeated administration of an allergen extract. So if a patient is allergic to pollen, it means that you're continuously exposing them to pollen, what they're actually allergic to, in order to provide long-term relief of symptoms. So in allergic rhinitis, we're talking about providing cure and therefore improving quality of life. And there's also an element of delaying sensitization to other aeroallergens. How does it work? In a nutshell, in the immune system, the immunotherapy just tries to decrease mast cells, basophils, and eosinophils, and therefore producing high IgG4 and IgA. So there's a shift from T helper 2 pathway to T helper 1 cells, and therefore an increase in T regulatory cells. And this all occurs during immunotherapy. Interleukin-10 plays a crucial role in inducing tolerance of the immune system. Who do we give immunotherapy to? Patients with allergic rhinitis, patients that have allergic asthma, systemic anaphylactic reactions to wasps or bee stings. Atopic dermatitis, but this is not an indication, a definite indication. Before you even consider immunotherapy, you have to make sure that the patient has immunoglobulin type E, IgE, that when you do skin prick tests, they're positive. When you do bloods to specific IgE, they're actually positive. So you cannot consider a patient for immunotherapy if they do not have the presence of IgE. The kind of patients that are candidates for immunotherapy are those that have been on intranasal corticosteroids and are still not controlled on their meds. Those that can avoid allergen. I mean, patients that are allergic to pollen and they spot somebody who's a cricket player, it's just difficult to avoid grass, for example, and those kind of patients are good candidates for immunotherapy. However, these patients must be able to comply to protocol. So if you have a patient that you think is eligible for immunotherapy, but they're not adherent to the intranasal corticosteroid, that makes them not a candidate, because it involves being adherent to the immunotherapy. And we've seen a lot of dropout. Sister Donna is the one who runs the immunotherapy quite a lot in South Africa. And there's just been, there is a high rate of dropout because of lack of adherence. So before you say yes to a patient, you must make sure that they'll be able to adhere to protocol. Contraindication in patients that have uncontrolled asthma. Patients that are pregnant, you cannot initiate immunotherapy unless they are on maintenance already. Patients that, remember we're talking about allergic rhinitis and not B. So patients that are less than 5 years would like to defer until they actually turn 5. A patient who's not able to comply to protocol, patients that have medical or immunological diseases, as well as patients that are on beta blocker treatment. So some of your hypertensive patients that are taking beta blocker. And that's just because it makes it difficult to manage if there is anaphylaxis. So last year I had a 45-year-old male that travels quite often, very high profile patient, who presented with worsening of symptoms. So worsening of sneezing, runny nose, and also experiencing recurrent throat infection. Very miserable patient, was not sleeping well, snoring at night, very obstructed, tired during the day, not functional during the day. His work was affected, his sleep was affected, his quality of life was affected. And he had tried different kinds of intranasal corticosteroid. He was adherent, he knew how to use his spray, and he was really adherent. But his symptoms were unfortunately not controlled. That you would like to consider for immunotherapy, provided that you have identified what they're allergic to, that there's a positive skin prick test or specific IgE to a particular allergen. This particular patient was allergic to grass. I'd just like to highlight that allergic rhinitis affects behavior because of lack of sleep. It affects learning. It affects productivity at work. Loss of focus or concentration. You know, you get kiddies that are really restless, moving around, and one starts thinking about ADHD, but they're just very obstructed and not resting enough. It affects memory, it affects daily routine, it affects sexual function, and also has psychological problems such as anxiety or depression. So when you see these patients with severe allergic rhinitis, they may even have anxiety or depression because of their symptoms. And these are the kind of patients that you really would like to consider for immunotherapy. The protocols are different. It depends in which country you are. Some countries can actually do rapid protocols, and some protocols, the standard one is to give weekly injections if you're going the subcutaneous route. So you give weekly injections for 8 to 16 weeks, while we're increasing in incremental dosages, followed by monthly maintenance, usually over a period of 3 years. 5 years would be in B allergy. Patients are observed for at least 30 minutes. We make sure that they're okay, their temperature, their blood pressure, the peak flows are okay before they leave, before they get the immunotherapy and before they leave. Sublingual immunotherapy, very popular, very common. I personally prefer this, especially in pediatric patients. And this involves administration of drops or tablet of an allergen under the tongue. If it's a drop, it's got to be under the tongue, and it says for 2 minutes. And you can understand why it's not possible to or feasible to initiate under the age of 5 years, because the patient has to be able to keep it under the tongue for 2 minutes before swallowing. And of course, there are those local side effects such as itching, lip and tongue swelling. They're quite common in about 50% of patients. However, this resolves with time. How does immunotherapy modify disease? So that there's decreased disease severity, less usage of drugs, prevention of future allergens, and a long-term curative effect. I mean, patients that are on allergen immunotherapy have such satisfaction because in the long end, they're actually cured from their symptoms. So as I've explained, the subcutaneous immunotherapy and sublingual immunotherapy, and there's been research, randomized control trials, and research clearly shows that this is effective, especially with house dust mite and pollen. Okay, with regards to subcut, it's written seasonal allergic rhinitis, but Dr. Masocha has already classified those kind of patients have resolution of symptoms, whether they use skit or slit. And in terms of persistent allergic rhinitis, which in this it was written PAR, perennial allergic rhinitis, I think for just the sake of the kind of allergens that the patient might be allergic to, for example, house dust mite is typically produces persistent allergic rhinitis. These kind of patients, whether you give skit or slit, it both works. With subcut, it's shown moderate quality evidence, while with sublingual, there's high quality evidence. Long-term remission of symptoms. With subcutaneous, there's moderate quality of evidence, and with sublingual, there's high quality evidence. but really using either route, there is evidence that it actually works, especially in those two allergens that I've mentioned, house dust mite and grass. Okay, in children, there's more studies that are needed. With regards to local adverse reactions, I've already mentioned that there's itching, lip and tongue swelling with the sublingual ones, but it resolves with time. And with the subcut immunotherapy, there's pain and swelling around the area where the allergen is injected. Systemic adverse events are not common in sublingual immunotherapy. However, they can be seen in subcutaneous immunotherapy. With sublingual immunotherapy, the patient can just administer themselves under the tongue. With subcutaneous immunotherapy, it's got to be done at the specialist clinic. The compliance can be monitored with subcutaneous because a patient is coming in weekly for initiation and then monthly for maintenance. So you're able to actually tell if this patient is compliant or not because you are administering the immunotherapy. You know, obviously the drop rate is a bit higher, much higher in sublingual immunotherapy. The oral route is not recommended for inhalant allergens. There is oral immunotherapy for food, but not for inhalant allergens. Inhaled route, it's not recommended because it triggers asthma. There's the epicutaneous route where an allergen is placed as a patch directly on the skin, and it's been shown to be effective in grass pollen allergy. There's also the intralymphatic approach that involves injecting an allergen in the inguinal area under ultrasound guidance. This kind of route is not practiced in Africa. However, there are some centers that do, you know, the different routes, epicutaneous and intralymphatic. The key message is that patients that are not easy to manage with allergic rhinitis, please consider them for allergen immunotherapy because they may be candidate and that will lead to long-term remission of their symptoms. Allergic immunotherapy, as you've seen, is highly effective, either as a subcutaneous immunotherapy or sublingual immunotherapy, especially in grass or house dust mite allergy. And the clinical efficacy is accompanied by long-term disease remission. Thank you.